Good afternoon, everyone. Thank you so much to the chairperson, and thanks to the organizers for giving me this opportunity today to speak about a topic given to me, which is low-dose immunotherapy, the need for evidence to improve access to expensive therapies. So this is my presentation outline. So I'll be sharing a bit on what are immune checkpoint inhibitors, what immune checkpoint inhibitors can do, the identification of doses for immune checkpoint inhibitors, treatment optimization for immune checkpoint inhibitors, and the practice-changing trials for low-dose ICIs. So what are immune checkpoint inhibitors? So briefly, T cells have proteins that turn on an immune response and other proteins that turn it off. So what I mean by that? So these are called checkpoint proteins. So the checkpoint proteins, some checkpoint proteins, help to turn on the T cell and to become active and, for example, when an infection is present. But what happens when the T cells are active for too long and react to the things that they shouldn't be, they shouldn't, right? So they will start to attack all the healthy cells and tissues. So that will be the where the other checkpoint help the T cells to switch it off. Okay. So some cancer cells make high levels of proteins. So these will actually switch off the T cells. And what happens when the T cell should be really attacking the cancer cell, then the cancer cell will actually put a push button towards the immune response and start to switch it off, and then the T cell cannot recognize and kill the cancer cells. So if you develop an antibody against any one of this, so it will be you can block the secret handshake between the immune cells and the cancer cells, allowing the immune cells to now recognize and kill the cancer cells. So within this mechanism, different targets work on have different sets of drugs. For example, the anti-CTLA-1 drug, we have ipilimumab, and then anti-PD-1 we have pembrolizumab, nivolumab, etc. And then anti-PD-L1 we have atezolizumab, durvalumab, and etc. Okay. So checkpoint inhibitors were first approved for advanced skin cancer. Now, these drugs can treat for more than 25 types of solid tumors. So these are the examples you can see. Immunotherapy can treat squamous cell head and neck cancer, malignant melanoma, Merkel cell carcinoma, and you can see there are a lot of cancers. Okay. So what are the importance of ICI here? Why is it called, it's a breakthrough in the oncology field now? It is because the ICI enable to prolong the overall survival in patients with metastatic disease and providing new therapeutic indications in earlier stage setting. So here are some data that I would like to share on few prevalent cancers. So the first one you can see, it's a lung cancer trial, Keynote 189. You can see the difference between the patients in pembrolizumab combination and also placebo chemo combination. So you can see that the overall survival of patients in the pembro arm, it's about 70% at 1 year, and then in a placebo combination arm is about 50%. So the difference in the 20% is actually very significant. And what about the next one? Let's look at it. Head and neck cancer, right? So you can see at 1 year survival analysis, the patient in pembro plus chemo is the overall survival is about 53%, and then in a chemo arm is about 44%. Maybe this doesn't look very significant, but what happened at 24 months? You can see that the patient, the red curve, the patient in the cetuximab with chemotherapy arm, the graph is actually reaching towards 0. So eventually, the patients in this group will pass out. And what about the blue curve on top there? You can see from the 24th months, about 25% of group of patients actually showing a very steady survival. So that shows that a bit of group, small subgroup of these patients are actually getting cured from IO. And the next one, the Keynote 716 trial for melanoma patients, also there was a significant outcome in the disease recurrence for the patients in a IO arm. And this is a triple negative breast cancer trial, Keynote 522, which is very aggressive cancer. We can see that there was a significant difference in the pathological complete response for the patients in the pembrolizumab chemotherapy arm. Okay. So fast, isn't it?
It's learned enough.
Okay, so why? But after we look about the importance, so how the doses of ICIs were identified. So when a new drug is given to a patient for the first time, we call this as a phase 1 clinical trial. So during this time, we will test the dose, right? So what we do traditionally is we give, here you can see, right? We give 3 patients with the dose at the first level and see what happens. And then we see the patients at the second level and see what happens. And then this will continue until we see something called dose limiting toxicities. So you can see at the stage 4 there, 2 out of 3 patients are actually having adverse events. So what happens if we continue to give the patients with a dose at the DLT? The patients will face a very severe adverse events that may be not tolerable, right? So what we do, we give them a dose lower than the DLT, which is called the maximum tolerated dose. So this maximum tolerated dose is what we will be testing and evaluating in phase 2 trial in cancer patients, where you compare with the control dose. And then what happens is that they come up with regimens where they base it on the weights. So here are some evidence. Okay, so like the previous slide, what is the importance of testing the maximum tolerated dose? This is because we want to test the drug at the maximum dose to know whether the drug will work or not. If you test it at a suboptimal dosage, then maybe the result will be a negative trial. So here are some phase 1 studies that I would like to show how the MTD and DLTs were identified. So the first table you can see, pembrolizumab every 2 weeks. At first, patients were given 1 mg per kg or 10 mg per kg every 2 weeks. And then you can see there, every 3 weeks, patients given 2 mg per kg or the 10 mg per kg. The adverse events were not very significant. Yeah, so the same goes to the bottom ones. The adverse events were not very significant for the patients given low dose, 3 mg per kg or 20 mg per kg. So no DLTs were observed in all the studies and no MTD was defined. Pembrolizumab was well tolerated across all doses up to the maximum administered dose, and AE were of grade 1 and 2. Where patients faces like fatigue, nausea, and pruritus. And similarly for nivolumab, the patients were well tolerated up to the maximum administered dose. And the commonest AE was lymphopenia. About 10 patients had that. So then, the FDA approved flat dosing regimens, where Nivo and Pembro were given 240 mg 2 weekly, and 200 mg for pembrolizumab every 3 weekly. And then subsequently, higher dose and extended dose were added to all approved adult indications based on the validated clinical trials. Okay, while immunotherapy has been touted as the biggest breakthrough in oncology, it is currently not available in the Malaysian public hospitals. It is not listed in the Blue Book. Why? Because of the limitations in the cost, right? Patients with economic constraints, living with cancer, and then patients who do not have enough insurance coverage will not be able to access to this type of treatments and drugs, because You know, immunotherapy costs about 300 to 600K for 35 cycles for up to two years per patient. So it is therefore urgent for us to find better ways of delivering effective treatments to our patient. And for immune checkpoint inhibitor, this is possible. So why? This brings me to the next slide. So what we can do, we could consider optimizing the IO. That will actually reduce the treatment, prevent over-treatment, and also potentially the toxicities. So, instead of giving 200 mg, can we give 100 mg? Instead of giving 3 weekly, can we give 6 weekly? Instead of giving 1 year treatment, can we give for 6 months and get the same outcome as the currently approved regimen? Can. Let's see the data here. Here's the science. So look at the first graph. This is a study, a phase 2 study of kidney cancer, where patients were given Nivo of 0.3, 2 mg per kg, and 10 mg per kg. And you can see the overall survival curve is not very significant. It's almost the same across all the doses. And then the second one, this is a real-world data comparing nivolumab 20 mg and 100 mg. The survival was also no difference in the survival. Okay, next one. These are 2 studies comparing the receptor occupancies. And you can see patients who get lower dose and the maximum dose, there is no difference in the receptor occupancy. And here, it's not just the low dose. When they compared the data at 3 weeks, 6 weeks, and 9 weeks, the patients had the similar receptor occupancy. Okay. Sorry. But what are the limitations between this slide and this slide? Look at the yellow one. These are all the exploratory analysis. It's not powered statistically. So doctors cannot use this to prescribe the treatment for the patients. Let's look at the next slide. These are also some examples where patients were given shorter duration of treatment. So there is a trial called Checkmate 153. Patients given nivolumab 2 years versus 1 year, there was no difference in the overall survival. And there is a case study of 22 patients with advanced lung cancer who were treated with less than 6 months, had a similar overall survival with patients treated with for 2 years. So we need this kind of optimizing treatment trials which will be a practice changing to reduce cost burden, potentially the toxicities. Yeah? So this is the exciting trial that I would like to highlight. So this is a phase 3 study conducted in India, which is particularly very exciting because they used 20 mg of Nivo every 3 weeks, and then they compared with the chemo alone. And what happened? It showed improvement in the survival about 27 to 27.1%. From this graph, we can look at the proportion of patients that have very long term survival to this very lethal cancer. So this is first practice changing low dose trial. So based on the findings of this randomized control trial, doctors can now start to give the patients this kind of dose for head and neck cancer. Currently, this is only for head and neck cancer. So we need to explore for other cancers because it is not clear whether the same will work or not for other type of cancer. Like for example, lung cancer, we could explore in lung cancer because, at only 9% of 5-year survival, it has the worst cancers of all cancers in Malaysia. So, what are the take-home messages? IO is one of the biggest breakthrough in oncology, but the availability and access is limited because of the dose. So, based on preclinical studies, case reports, phase 2 studies, and other retrospective studies, it is said that it is proven that low-dose IO may work. And currently, there is only one RCT has been conducted so far. Establishing low-dose IO protocols will be very challenging, but it is a necessary step for us to take forward to enhance the global access. And it's not just about the cost, it will also result in fewer immune-related toxicities and increasing the tolerability of the patients towards the treatment. Hence, Phase 3 RCT is urgently needed across a range of cancers to establish the clinical evidence to enable increased access to life-saving immunotherapy. These are likely going to be investigator academic driven. So with that, I thank you so much for listening. Let's reverse the big C together. Thank you.